Well, we're on. Okay, I am going to call the meeting to order. Before we get into the agenda, I'm going to do some thank yous to people who are leaving and some intros and welcome to some of the people that are joining. First, for those of us in the room, it's been over 3 years. This is so nice. It's really good. And we would like to make a pitch that in the future, people come in person. Now, we know that this was one of those times when people didn't necessarily know it was going to be in person. They may have planned a meeting before and not allowed time to travel, et cetera, et cetera. But as much as we can, it would be great to meet in person. So before I get set about the agenda, let me thank 2 people who are leaving. One is Bill Geary. He's not here, but we are going to tell him that we recognized his service for many years. He was a wonderful, wonderful member of this council. He was a contributor on every topic and particularly helpful in IT issues, operational issues, and we just thank Bill a minute. Couldn't thank him enough. The other person actually is here, but she's going to leave at the end of the year. My friend, you know, it's one of those things where Meredith is leaving us. And you have been an amazing member. I have to admit, personally, I used to look at conversations and see what where you were going with them and say, okay, I better follow and listen to that one. You were a beacon of knowledge. Your work, particularly on any issue regarding policy, research, you will be missed. So thank you for your service. And Bill.
Thank you, Faye. Thank you, Lauren. It's really been a pleasure. I have learned so much from working with all of you, and I just have the deepest respect for CHIA, the staff, the leadership. It's really been wonderful, and thanks also to my fellow council members.
Again, thank you, and welcome to new members. We have 2, and the first is here, and her name is Adrienne McIntyre. And both our new members have very long and wonderful biographies and CVs. I'm not going to read it all or tell you all about it. But Adrienne is an assistant professor at the Harvard School of Public Health with a focus and interest in health policy and politics and health and intersection. And we look forward to your contributions on those issues as well as many others. Everybody here is here to opine on every topic. So it's not like we sit here and this is our topic because we have a wealth of knowledge around the table. Jean Yang is here. She's right over there. Wave so people can see her. Hey. Also a wonderful long biography. Is currently the CEO of VinFen, which provides services to mental issues, disabilities, a wide variety, primarily community-based, as I understand it. But a lot of people know her work because she was at, I think you were at Tufts, you were the Children's ACO, you were at the Connector at the beginning. So even if we didn't know you, we knew your name when you met that were, you know. So you bring a wonderful wealth of knowledge and experience, which is absolutely terrific. And do I see, is that Karen? No, Amy is new to the group too. I'm sorry. Terrible to be old. Let me see. Yeah. Amy is joining us and welcome to the group. And again, is an appointee from Health and Human Services. Did I miss anyone? Yes, the council. We have a quorum, I'm happy to say. So the meeting is now in order and we are going to start with the minutes. And for those of us that were in student government, you can vote on the minutes, even though you weren't at the meeting, or you can abstain, which is fascinating, but that's the rule. And because we have people online, we have to do a roll call. So before we go to the roll call and approval of minutes, so any changes, additions, thoughts, you all got it in advance. Anybody on the screen? Hearing none. I'm going to do a roll call and I will get my glasses. David.
I'll make a motion to pass the minutes.
Thank you. Would I have a second from someone? Right. Okay, we got it. Now we'll go to David and say.
Aye.
Aye. Actually, I wrote this down this way. I shouldn't look around the 2 rooms, should I? Jean.
I was not here, so
Right.
therefore I would.
You have a choice. You may approve them if you wish. You can actually say no, or you could say abstain.
I think I would say abstain.
Okay,
Well, abstain as well.
okay. Isn't it fascinating?
It is.
If people who weren't at the meeting can't approve them? Anyway, Laura, I'm sorry, Laura.
Oh, sorry.
Around the table.
Yep.
I think I will abstain as executive director. I don't know.
Oh, that's right, I forgot. Cassandra.
Aye.
Aye. And, Sandra.
Aye.
Great. Brent. Aye. Okay, now Laura.
Aye.
Meredith.
Hi.
Niels.
Aye.
Aye. Faye, yes. Anybody else? Did I miss them?
I think I need these.
Oh, Amy, you were there.
Yes, I was there. Yes, I.
Amy, I'm going to get it right eventually. Thank you. Okay, and I. So the minutes are approved. You'll notice that there was a reordering of the agenda between the one that was sent out earlier and the one that went on, I think it was yesterday. Yeah, same topics, just a reordering. And that was simply to make sure that we had enough time to really dig into a conversation regarding workforce survey as it comes up. So we will hit the agenda with our executive director's report. Great.
Thank you, Faye. And I just wanted to echo the thanks and gratitude to Meredith and to Bill for all of your contributions. It's been an absolute pleasure both serving on the council with you, I think from its inception, and now in this new capacity, albeit brief. And want to also extend a warm welcome to Adriana and Jean. Really excited to have you on the board and excited sort of at this inflection point for CHIA, with a lot of transition and leadership change and some of the new council members and perspectives. We're really excited to have you joining us. So for the executive director's report, just wanted to go through a couple of highlights and updates, just to share what we've been up to here at CHIA for the last couple of months since we last met in June. The first item is the brief budget and legislative update, so I'll turn it to my colleague Emma.
It's Lauren. So again, Lauren said we're just going to walk through quickly what the updates have been on the budget and legislative front since our last meeting in June. So the governor signed the FY24 state budget in early August. That included a $33.394 million appropriation for CHIA, which was consistent with our request and fully funds the agency for this fiscal year. There was also a number of policy initiatives included in the budget, two of which directly pertain to CHIA. The first one directs the Health Connector to extend eligibility for the premium assistance program to individuals between 300 and 500% of the federal poverty level. And that is set to begin January 1st, 2024. That language further directs the connector and CHIA to evaluate the pilot program with reports due to the legislature in 2025 and 2026. The second section requires DPH to issue regulations to create a statewide standard care protocol for stroke patients. And as part of that, recommend quality and utilization measures to CHIA as part of the standard quality measure set. And then regarding other legislative updates, supplemental budget passed over the summer that included $180 million for financially strained hospitals. And CHIA data was cited as part of the eligibility criteria for hospitals who are eligible for those funds. We are also continuing to track priority healthcare legislation, including the Primary Care for You bill, which had a hearing last month, and other bills that would have a significant role for the agency. And then lastly, we recently completed 2 mandated benefit reviews, and we are about to start a new one on insurance coverage for biomarker testing. As a reminder, the legislature refers mandated benefit bills to CHIA for review. And as part of that, we look at the medical efficacy and estimate the cost impact of the proposed benefit, which would require coverage of either a condition, treatment, or a specific provider. Any questions?
Thank you.
Thank you, Emma. All right. Next up, wanted to go through a couple of recent publications. We've had a number, this is not exhaustive of our recent publications since June, but wanted to highlight a couple of recent ones. So as part of our health equity series, just last month, we published a report that looked at hospital utilization stratified by race and ethnicity. We also, I think it's at the end of September, released our FY 2022 Hospital and Health System Financial Performance Report. New in this report, we included temporary staffing data for the first time. I think this was a partnership with the Hospital Association, given the impact that temporary staffing and labor have had on hospital and health system finances. We felt like it was a critical part to track as part of these financial performance reports. Just some quick hits from that report. In FY 2022, where the hospitals and health systems showed a statewide total margin of negative 4.2%, which is a decrease of negative 9.2% from the prior fiscal year. Although I will note that preliminary data through June 2023 is showing a positive reversal of that trend, showing a statewide total margin of 1.6%. So as you know, the last couple of years have been very volatile. A lot of the impact, some of the factors that have been impacting the financial picture for hospitals and health systems has had a lot to do with the investments books, or the hospital and health systems in lines of investment, as well as a lot of the state and federal COVID funding that has come in. So all of those sort of puts and takes have led to a somewhat volatile picture. While we did see a negative, fairly grim picture in FY 2022, we are seeing a reversal of that trend, and the early numbers, a partial year of 2023 is showing margins reverting back into the black. The report also showed temporary staffing costs totaled $1.5 billion in fiscal year 2022, which is obviously significant. It's a doubling from the prior year, and a 5x of what temporary staffing costs were pre-pandemic. But I think that these are trends that we're going to be continuing to track both on a quarterly basis, and at this time next year we'll be releasing our next annual report that looks at data through hospital fiscal year 2023. Most recently, just last week, we released our second edition of the primary care expenditure report. And new to this year's report, we tracked expenditures at the provider and payer level. And again, this is just in the spirit of transparency and greater accountability. This more in-depth and granular expenditure report will allow us to look at, where are the bright spots in the system, where are we seeing expenditures, where are we seeing entities, provider types that are behind the curve in terms of primary care expenditures. I think this is all tying into the work in legislative proposals that Emma mentioned around how do we support investments in primary care. So more to come on the legislative front, but we're using these reports as well as the primary care dashboard, which we'll provide an update on in a little bit. All of those are to sort of provide the fact base for a lot of this policymaking work. Finally, just to note a couple of reports that are forthcoming in the next quarter. We will be releasing our third edition of the prescription drug utilization and spending report, as well as a new report that will look at total medical spending by zip code. So that will allow us to look at trends and variations across communities in the Commonwealth. So we're very excited for that one. Let me pause there, see any questions, comments, feedback on the publications.
Just on the hospital financial piece, I just wanted to be on the record commending CHIA for doing the breakout of the temporary nurse staffing expenses. That's been something that at the Health Policy Commission, we have been also tracking and really trying to understand the dynamic there. We obviously had survey results that the Mass Hospital and Health and Hospital Association had put together. They had estimated 1.5 billion in that fiscal year. So good to see the data collection that CHIA did, both validating that. And I also think do want to confirm with you, Executive Director Peters, that will continue to be a breakout in future data collection cycles, so that we'll be able to continue to track that.
Yes, absolutely.
Great, and I think it's really good that we're collecting that at the state level through CHIA and not just, relying on member organizations, because it's just really important to have it for all hospitals in a very kind of clear and defined way. I would say one of my ongoing questions with the temporary nurse staffing and even breaking it out and saying it was 1.5 billion. I think I want to understand a little bit more that may not mean 1.5 million in brand new expenses. Certainly some labor costs shifted from non-temporary to temporary. And so it's not necessarily that it's just 1.5 in new expenses. There's probably some offsetting, but I think being able to track that and look at both components will help us really understand how the labor market is stabilizing for the systems.
Yeah, I think that's a really good point. And to provide more context, the 1.5 billion represented about 3.9% of total expenses. And again, to your point about some of that is supplanting other expenditures. There was a lot of noise, for example, in the FY21 data in this space, where there was one hospital that had a fairly protracted labor strike. And so they were almost solely relying on temporary staffing costs or labor in that and during that time period. So there are different sort of factors and variables. And in some instances, there's noise in the data that I think is helpful to understand that context.
Yeah.
But I think it's a point well taken that we should not be just looking at this as solely new, incremental, net new costs for hospitals.
But having the data will help us be able to identify those patterns.
Yeah, I want to second how important I think this is because of the expenditure issues, as well as the implications for quality, as we know, really important to track this.
That was actually where I was going. Just one of the major concerns about temp agency use is quality. So to the extent that we actually can take some steps to measure that, so that it's more acute on the more serious on the long-term care side, because the continuity and the relationship is very much compromised. But even on the acute side, I would imagine the impact is measurable as well. So what do you think about that?
No, I think that's a really good flag and something for us to think about. And we'll take this back and identify perhaps an opportunity to, whether it's best suited for inclusion or some way to tie it into the hospital financial report, or I'm thinking through the workforce surveys is something that we should be looking at, and how can we kind of thread these things together as we're looking at finances, capacity, and how do we layer that quality component on. So I appreciate those comments.
Any other from room, or how about anybody trying to get on to the video? All set? Great. Thank you.
All right. The next agenda item that I wanted to quickly highlight and touch on is our strategic planning efforts. So just as a refresh, CHIA undertook a strategic planning exercise this past spring to develop an articulation of our priorities and objectives as an agency, as well as really create a roadmap for implementation over the next 18 to 24 months. I think we're thinking, 12 to 18 months. We're thinking about this through calendar year 24. And really the goal of the strategic planning exercise is to inform how we as an agency make decisions, how we allocate resources, staff time, and something that we can use it as we manage in both internal and external demands and requests for data, information, and analytics. We brought the strategic plan to the June council meeting and really appreciated the robust discussion that we had and all of your feedback. We've since incorporated the council's feedback into the plan, and then used the months of August and September as our leadership team really fleshed out over 60 tactics that will really serve to implement each of the goals and objectives that were outlined in the plan that you all saw in June. And so for each of those tactics, we've assigned an accountable executive owner, the milestones, deadlines, and plan to bring every 6 months, we'll plan to bring sort of where we are with that, with implementation back to the council for feedback, and really just that assessment of where we are and where do we need to go, where are there areas that we need to perhaps pivot or accelerate. So we will plan to use the next council meeting to really do a deeper dive into where we are within the strategic plan.
Great, and I recommend that our new members have an opportunity to take a look at that plan.
Yes.
It was a robust, very robust conversation at the last meeting, lots of good input, and look forward to the next conversation.
Yes. And once we have the opportunity to do sort of a deeper dive, 101 briefing, we can go through the strategic plan in whatever detail would be helpful to you. All right, the final item on the executive director report. I wanted to highlight an exciting milestone that we hit earlier this week relating to our work with Mass Health implementing their health equity incentive program. But just as context, under the recently authorized 1115 waiver, it included over $2 billion for initiative across 5 years. Really gets at reducing disparities in quality access within the equity domain. And CHIA is supporting, has been working over, I think, over a year now, working to support the implementation of this by standing up a system to collect and process the REL SOGI data that we're pulling directly from hospital EHRs on Mass Health's behalf. So we'll intake, process, curate, and send over to those files to Mass Health for their evaluation and implementation of this program. So what we went live, the system went live earlier this week, and hospitals have until, I believe, the end of the calendar year to submit their first quarterly data submission as part of this program. So kudos to the team here. I know it's been a lot of sort of heavy lifting to get that system up and running, and a lot of work and engagement with not only Mass Health, but the hospital community, because this is really at the on the frontier of being able to collect in a systematic way REL SOGI data. So this is, I think, the first step in a longer approach and journey to getting a stronger, richer health equity data foundation. Any questions on that?
Yeah, David, and then.
Go ahead.
Oh, I was just gonna say it's really exciting work and I appreciate the update. Is CHIA's role here as a kind of processor and transmitter of this data? Does that include standardizing across potentially incompatible relevant SOGI data sets that you're pulling from the EHR, or mostly is that data coming in kind of an apples to apples standardized way?
Sure, I can make a first attempt in answering that, and then we'll have my team sort of confirm the accuracy. So in terms of standardization, there was already over 12 months of work as part of the quality measure alignment task force to come up with standardized REL SOGI data fields or data stacks. And those are what is sort of guiding and that hospitals are using to submit data to CHIA. I will turn to the team to see if there's any additional standardization work that's happening. Probably, because it's always more complicated.
I think the Mass Health Working Group that included our agency also, they made some minor enhancements to the QMAT standard. There are additional options in the QMAT standard and also feedback to the hospitals. But that largely it mirrors the QMAT standard.
Great, thank you.
Yeah, David.
Thanks. I'm really interested in this, and so happy to kind of take this offline. And first, just on that last point, I just want to make sure that if there were some tech modifications made from the QMAT, that we're communicating that back to the QMAT so that they're aware of that, and maybe they want to would consider making those modifications. Just so I'm understanding this. So this is only for patients who are getting care in a hospital. And they're being identified as attributed Mass Health ACO patients. The information is being collected by the hospitals, and entered into the EHR. What is the step between like EHR to CHIA?
All right, I'll take a stab at this, and then folks can throw the flag if there's anything wholly inaccurate here. So the data will, for each patient that comes in that is attributed to an ACO or an ACO affiliated hospital, the treating physician will fill into the EHR as complete as possible, as complete as the patient is willing to sort of volunteer and provide that information. That data then gets sent over to CHIA, and I think what CHIA's role is primarily is objective in nature, in that it's taking who are the Mass Health members. And actually, I should back up, because all of the hospitals are going to submit, my understanding is, all EHR data, I think, beyond just Mass Health. And so I think what a lot of the work on CHIA's end is taking the file and narrowing it to the relevant or germane patient population that Mass Health is looking to sort of evaluate and measure hospital and ACO performance on in this program.
Is it all care at a hospital outpatient? If it's a physician group owned by a hospital, is that being pulled in, or is it just inpatient, outpatient? What?
It's the inpatient, outpatient of the hospital. There's been discussion about extending it to the practice. There's some implications to how that data would actually get transmitted to us if that happened, because very often that data is contained within the sites rather than through the hospital system. So the first foray into this is the acute care hospital itself. And just to confirm, we are getting all the patients at the acute care, and the CHIA data set will contain all patients. The Mass Health will get the Mass Health members that either provide a Mass Health ID or we can attribute to, but that we will also have the relevant social data for the entire patient group of those hospitals available for our sister agencies.
It's very exciting, and as you said, Lauren, I think a first step of building a system that will really help us to be able to fill some of the gaps in our current data collection. So great work.
Yeah. And I think we'll dive into the health equity work in a moment. But I think to your point, when you talk about something that you said sort of just spurred a point worth underscoring, which is this is data collection at the time that that person is already in the hospital. And so I think as part of our broader health equity, a bit of a spoiler over here, as part of the broader health equity strategy, data strategy that she is working on, we want to think about what other data streams should we be collecting to help address some of these disparities more upfront or upstream, so that it's not just once someone lands in the hospital, are we collecting this information, but how do we get payers and others at the table so that we can start sort of informing strategies more upstream in the care system.
Other questions? That was helpful, because many of us really don't understand or didn't understand. We now know a little bit better. Any other questions from anybody on the call? Zoom? Anyway, I'm going to paraphrase because I'm probably the least knowledgeable person to what I think I just learned. So we are collecting from every hospital's medical records, every patient's information. And we're doing this because the first question, because I was asked why, who are we doing this for and why are we doing it? So we are doing this for policymakers, plans, hospitals, providers, to make sure that we're thinking about health equity and understand what's really happening. And we started with looking at ACOs within Medicaid.
I would say that I think that the one tweak would be that the genesis of this particular health equity initiative it was really the authorization of that health equity incentive program in the Mass Health waiver. So CMS authorized this program as part of Mass Health's 1115 waiver. I think Mass Health came to CHIA to ask for support in standing in the implementation, because we have the infrastructure and sort of history and expertise in large data set management and being able to intake all of those files from the hospital EHRs process and then put back to Mass Health. So in some ways, CHIA is a sort of operational playing a operational supporting role. But we feel like this is in full collaboration with Mass Health, and I think we all have sort of the shared goals of let's use this, the door is opening and through this initiative to collect World SOGI. And going back to your summary remarks, I think that the broader goal here is the more information and the data that we have on World SOGI, I think it helps to inform both policymakers and the industry alike to implement and take on some targeted approaches to reducing those disparities.
So if I'm understanding correctly, what we're really trying to do is to create markers. We're not particularly trying to connect the data with hospital procedures and outcomes yet.
Yeah.
What we're really trying to do is just create markers for ACO attributed population. Okay, I can understand that you start with the hospitals because they are larger entities. The plumbing work is relatively concentrated. But my concern about that is there's a lot of duplication because the same patients could land at different hospitals for different procedures. So versus, you know, in theory, if you go with the health plans or even the primary care, the data will that by definition be singular. Wouldn't that be technically a little bit easier if you're just trying to create marker sets?
Yes, I think that's right. We were not necessarily at the table when Mass Health was negotiating the waiver, and I think that we have sort of that shared vision, though, that perhaps the best place to perceive and really target this data is from the payers. And we think that even this step, like in a perfect world, maybe the hospital would not have been to the first out of the gates, but to your point, it does create that mechanism. It was part of the Mass Health waiver agreement. But we think that it presents a lot of opportunity because we will be able to, at that the point in time that I think we all hope to get to, and we're collecting the World SOGI data from payers, there will be countless ways that we can layer that data with hospital and tie it to the eligibility membership data from the payers. So we can, I think there will be exponential analytic opportunities once we're able to collect those parallel streams, both from the hospitals, providers, and the payers.
But I would just emphasize the plumbing work, if you will, where CHIA collects data from the hospitals is extremely valuable. So even without thinking about the full potential of the analytical outcome, just being able to collect that data and process the data is very powerful outcome.
Yeah. So
I agree. Huge step forward.
I'm sorry, who's trying to talk from the screen?
I just said I agree, huge step forward. This is really critical information. It's been beyond our grasp for a long time. So this is really exciting to make a step forward.
Yeah.
So one challenge, obviously, with measuring social risk and asking people to solve for core things that we define as social risk is that they may not be comfortable disclosing that. And comfort levels in disclosing may vary across provider types, across communities, across individual demographics. So I'm curious if it's going to be collected consistently insofar as whether people are going to be asked interpersonally by person versus sort of entering in a way that feels more anonymous. We know that surveys look different. If you have to look someone in the face and tell them something. And I'm also curious if we're going to be able to distinguish between the hospital did not ask the way that they were, like they just didn't ask because the system wasn't updated versus the individual chose not to respond to this question. That might shed important insights into where patients feel comfortable and where they don't. So I'm just curious if there's like infrastructure around that.
Yeah, so no, I think it's a really good question, and I know that there's been a lot of thought given to those varying dynamics. As I mentioned, there's not only there's a group formed to land the standardized data specifications, but that same work group has been working with hospitals to provide technical assistance and training to help hospitals with this very conundrum, which is how do you help move the needle and get patients to sort of get bought into why this is important, why they should be sharing this information. And I think that is going to continue to be one of the biggest challenges when we're collecting the RELT SOGI data from any entity, whether I think payers, this is the number one reason we hear from payers about their concern. So taking the next step in the space is we can only provide you, CHIA, as much data as we get from our members. And so I do think that there are more conversations that we should have, and would love to get your feedback. And if you have insights, expertise in thinking about ways that we at CHIA, not only as sort of the implementer and collector of data, but how can we be partners with providers, payers, to help them collect this information.
Terrific discussion, and I think we're going to move on unless there's any point somebody feels compelled to make it more. And we're going to talk a little bit about health equity at the end as well. Great. From the conversation, I'm taking back two real thoughts. One is the conversation around temp staffing, quality, and some of the issues raised about data. And the second is that obviously great discussion we just had in health equity, which I'm taking as this is a really cool beginning step. And we're not quite sure how it's all going to end up. And it's got lots of journeys to go on, but it's absolutely the right thing to be doing. That's exciting. That's great. So we are going to turn to CHIA priority area update. We spend most of our time in workforce, and we are going to have Kat, and I'm hoping I'm pronouncing your name correctly. Wachuku?
That's correct. Thank you.
Was that correct, Kat?
Yes, that was correct. Can you hear me okay?
We hear you just fine.
Perfect. Yes, that was great. Thank you so much. Excellent. So if I'm going to facilitate the conversation on workforce, and please stop me anytime with questions. So I'm Kat Wachigu. I'm a senior manager on the strategy and research unit at CHIA. And on the next slide, this past May, CHIA launched a health and human services workforce survey to address definitely one of the most pressing issues in the healthcare system today. The survey will provide objective, systematically collected, and reliable evidence base to support both policymakers and the industry to address the workforce crisis in the state. And so this annual survey is a survey of provider organizations, and it will support the ongoing monitoring to identify significant changes in workforce staffing needs and challenges, as well as provide data to inform significant changes in workforce to inform state policies and programs in healthcare and human services sectors. In this first round of the survey, we've reached out to HR directors and other administrators within adult day health, ambulatory surgery centers, behavioral health, including a variety of settings like outpatient mental health centers, substance use disorder treatment centers, inpatient psychiatric facilities, as well as community providers. We've reached out to community health centers, dental practices, emergency medical services, home and community-based service providers or home health providers, hospitals, both acute and non-acute, long-term care facilities, and physician groups. Next slide, please. This survey covers both quantitative and qualitative information on workforce. So including information on capacity like vacancies and turnover, the racial and ethnic composition for select occupations and senior leadership, recruitment and retention challenges and strategies, employee wages and benefits, and a few open-ended questions on workforce impacts on access to care and policy recommendations from organizations. And so throughout the development and refinement of the survey, we have worked with provider associations, provider organizations, workforce content experts, and sister agencies to identify the occupations that are of particular challenge for each sector, while also balancing that with our goal of producing cross-sector occupational comparisons. So through that work, we identified that physicians, nurses, social workers, and direct care workers were important occupations to target for most sectors, and will really allow us to make some meaningful statewide comparisons. So for example, looking at recruitment challenges for nurses in nursing homes compared to nurses in hospitals. We are also asking about an additional 3 to 5 unique occupations within each sector outside of that list above, just to provide some meaningful information back to provider associations, and also hopefully to streamline some data collection efforts across agencies. Next slide, please. So as I previously mentioned, the survey was launched for select sectors starting at the end of May, and we've been launching additional sectors on a rolling basis since then. The last sector was launched towards the end of September. The current response rates really vary widely based on the amount of time that the survey has been in the field for that sector, the quality of the sample list that we have for that sector, our partnerships with the associations, the organizational size and bandwidth, and truly a variety of other factors. But we are targeting a 20% response rate on average for most sectors. To increase survey participation across sectors, we've been working closely with provider associations and state agencies like EOHHS. So each provider association has done some general outreach to their membership through things like email blasts and newsletters to remind them about the survey and encourage them to participate. And they've also done targeted outreach to folks who have not responded to their survey or those who've partially completed the survey to encourage them to complete the full survey. In addition, EOHHS Secretary Walsh recently sent a letter to provider organizations across all sectors, encouraging participation in the survey and really highlighting the importance of this workforce data for EOHHS and the administration. These outreach efforts have really made a difference to increase participation week after week for various sectors. And then we're also reviewing preliminary data. So in reviewing the preliminary data for select sectors, we have observed some gaps in the survey responses, particularly around the racial and ethnic composition of the workforce and wages and benefits. And so we're calling back organizations who've completed the survey to try to understand the barriers to answering some of those questions, and ultimately to see if they're able to provide some more information just to improve the quality and completeness of the data. Both the participation outreach and the data quality outreach are ongoing, and we'll be using this information to determine when to close fielding for select sectors with the aim of closing the survey for all sectors by the end of the year. We are proposing to use a dashboard format to release survey data on a rolling basis by sector as fielding concludes and as data is complete. And we're targeting to release a handful of sectors by the end of the year. Next slide, please. So we are proposing to release data in multiple phases. First, releasing sector-specific data by the end of the year for those sectors with the most complete data. And following that, in the first quarter of next year, releasing a fuller statewide analysis for key workforce measures. We're primarily proposing to release data in a dashboard format, an example of which is on this slide. So these are simulated data. These are not real data, but this is one way we could present the information for a particular sector. So this format would allow the viewer to compare some key workforce measures for specific occupations within that sector, and then also includes dropdowns to filter by occupation and by region. And this is just an example to give folks a sense of what we could produce, but we do want to spend some time today discussing this format and the priority measures to include in our reporting. We're also planning to conduct in-depth analyses and reporting on specific topical areas or for select sectors on an as-needed basis. And we're working with other state agencies to explore the feasibility of adding some supply-side measures to our reporting, specifically worker and pipeline data from other sources, and with the hope of enhancing our reporting. Next slide, please. And so I'm happy to pause here now to see if folks have any questions on what has been presented on workforce so far before getting into some of these questions for discussion.
That would be great if we could pause here and make sure that we all understand what it is, context for it, and answer any questions about the presentation before we get into a deeper discussion. Is there anything you'd like to add?
Yeah, I think Kat noted at the top, but just to, I suppose, underscore, the goal of this was really to provide that fact-based foundation in a standardized, centralized manner, knowing that this is probably the most pressing issue facing the healthcare system right now. And in light of the fact that there was sort of this gap in a centralized and standardized apples to apples data set on vacancy rates, turnover rates, race, ethnicity, composition, key metrics that have been at the forefront of a lot of these workforce discussions. CHIA earlier this year made the commitment to sort of prioritize this and conduct this survey on an annual basis. I very much view this survey as, in some ways, as being the first one, a pilot run at this. I think we are very much open to sort of getting feedback from not only the council, but also the industry. How can we streamline the survey tool, recognizing that we don't want to add more burden to any provider's plate and make the workforce problem even worse than it is. But how can we streamline it? How can we ensure that the data, that the output of this survey is really maximizing value, not only to policymakers, but also to the industry? What we've heard from the industry is that this data, both sort of within their own sector, but also across different sectors in the healthcare system, is helpful for benchmarking purposes. And so I think that is the element that I know providers are most excited about, is to be able to say, all right, what are our vacancy rates compared to other similarly situated nursing facilities around the corner from us, or across the state from us? How are our RN vacancy rates, turnover rates compared to the hospital down the street? Are they poaching all of our staff? Like, I think that these are some of the claims and assertions and the concerns that we hear from different providers and settings across the care continuum. And I know that they're looking forward to this opportunity to benchmark. And similarly, policymakers, other constitutional offices, the administration, the legislature, they're looking to this data to help inform where they're putting resources, what policy levers would they be making on the licensing front, on the reimbursement front. I think that there's a number of different elements and that are all integrated into this broader workforce discussion. And I think having this objective fact base that is not sort of yielded or provided by a trade association, but rather an independent sort of objective source is going to be critical to move some of these conversations forward. That preamble.
No, that's great. That was great context and the kind of questions and who's going to be looking at it and why. Because for me, it was very helpful. Other questions before we get into the specific discussion items, just about the data, how it's working.
What's been the response rate so far?
Yeah.
Sure, yes. Yeah.
Sector, but Kat can speak to some details.
Absolutely, yeah. So like I mentioned, we launched the survey sort of on a rolling basis. And so there are some sectors that have been in the field since the end of May. And there's one sector that we just launched 2 weeks ago. And so the response rate really varies depending on the time in the field and the quality of the list of people that we're reaching out to and that sort of thing. There are several sectors that have response rates in the 30 to 40%. There are other sectors that have response rates slightly lower than that. And so it really is a range and it depends on a variety of things. But yeah, definitely those that have been in the field longer, those that we have that association partnership with, we're definitely seeing more responses. And the letter from Secretary Walsh really did increase survey participation across sectors. And that I think just went out maybe a month ago. So, we're still sort of seeing things, different outreach strategies that are improving the response rate for various sectors. Hopefully that answers your question.
I'm sorry, can you put it so we can see everybody? Sure. And everybody has the discussion questions in front of them to stir them. David had a question.
I was just gonna building off of the kind of the outreach question. Kat, I'm sure you've thought about this, but there are big health systems that have a lot of these people. I mean, getting the biggest systems to fill this out for all of their component pieces could get us a long way. And so I would not say that there's anything I could do that Secretary Walsh could not do, but if there are big systems that are not being resistant or not understanding the value here, I would certainly be willing to make a phone call and emphasize how important this data collection is. So getting the big systems, I think, could get us a long way.
Appreciate that, and we will certainly take you up on that.
And David, just to echo that as well, I'm sure Secretary Walsh would love to tag team with you to make those personal phone calls as well. So definitely on behalf of EHS, we're absolutely open and ready to do some of that more targeted outreach if the letter was not enough.
I'm going to call, because your hands up, I'm going to call Niels.
Thank you. Just really have a general question, and it really just continues the discussion about the response rate. I don't know if there's like a specific threshold by which you say you've got sufficient responses, but what's kind of the effect that you expect on the variation from the different sectors if you end up having a higher response rate in one sector versus another, if that, if you have any concerns with that skewing the data, or how do you expect to deal with that?
Sure. So to answer sort of the first part of your question in terms of like what we're targeting, we are targeting sort of on average a 20% response rate for most sectors. And that's something that's sort of a typical response rate for an organizational survey in the wake of COVID. Now that we're in this hybrid workplace environment, the place in which we are contacting people is slightly different. And so we are targeting on average about 20% for most sectors, and we are seeing many sectors well above that. In terms of the differences in response rates, we're working with our survey vendor to think about statistically how we would weight the data. And so, there's the actual number of people responding, but how many organizations would those organizations represent? And there are statistical ways that we can sort of address that. In addition to the actual response rate, there's also like the number of respondents. So for example, community health centers, there are 45 that we've reached out to. So they have a great response rate, but actual number of organizations that we have to also sort of consider that. And so we're sort of thinking like statistically, how can we make this data representative of all the community health centers? We're also considering region as another really important measure of how we can feel comfortable reporting out these results and making sure that we have regional representation of organizations within each sector.
Meredith,
Thank you.
Jean, and then Lauren. Meredith.
Great, thanks. I'm sorry if you said this already, but are you also collecting wage information?
That's right. Yes. So we do have a couple of questions on wages for both full-time and part-time staff for select occupations within each sector.
That's great. And my only other question is whether the detailed data would be made available in addition to the dashboard so people could look at themselves. Is it possible to release the data for researchers, for example?
I think that there's obviously confidentiality that we need to consider. And so I think right now, in terms of planning for our public reporting, it would be things that would not allow the viewer to identify which specific organization within that sector has responded. But I think, releasing data to researchers, maybe I'll pass that back to you, Lauren, if we have any plans for that in the future.
I was just curious because I think there's a lot of interest in sort of workforce issues across ownership types, for-profit versus not-for-profit versus PE owned, et cetera. So I think there could be some interest in doing some analyses that might not be important enough for the dashboard.
Yeah, no, I think we will certainly take that back. The goal of this was to make this provide a level of transparency and to again create this fact-based for public access. I think, of course, there's going to be nuances and there's going, I'm sure, our general counsel was here, there would be questions around like antitrust issues about what level we can share data and at the entity level. But I hear the ask, and I think we have a shared goal of making this data information as usable and widely disseminated as possible, but within bounds of the law.
And others see the obvious. Jean, was that part of what you were going to say?
A little bit as well, but I just want to start by applauding this work as a provider. You know, there's really nothing more important than this. I was going to make a point that is slightly on the opposite side of what David just said, but not in contradiction, just to make the picture complete. I'm really appreciative of this list on slide 10, just the completeness of it. It really covers every corner. So thank you for the thoughtfulness. I am worried about the smaller providers because the smaller provider, chances are the smaller the provider is, the harder it is for them to complete this request. And also most likely they have the most problems from a workforce perspective. So how you get to that is a real challenge. And survey fatigue is a very real issue out there. So I'm really glad, Lauren, that we're working with the trade associations, but I'm wondering whether there have been discussions around whether CHIA could really replace what they're doing, because that's not the sense that I'm getting. We just got requests from the Association for Developmental Disability Providers yesterday to complete another round of survey, for example, right? Which we're working on. So I guess the question is, have we looked at some of the sort of sector specific survey to at least make an effort to see if we could, to the extent possible, address all relevant angles so that we can truly centralize these surveys?
Yeah, so I think this has definitely been a topic of discussion with a number of the big associations. I think a lot of the associations at the outset were looking to this to replace their own survey. I think that there have been sort of intervening. I think since then they've at least one association I have in mind had their members say we really want to have do our own survey in parallel. I think oftentimes it's for advocacy purposes.
Yeah.
And it's a slightly more curated or tailored. And so I think that those are tensions that I think that the associations are grappling with. I think that as part of our planning for the next year's survey, I think that should certainly be a top sort of priority topic of concern or topic of discussion with the associations is how can we truly use this to supplant is what's missing from you that could help address your membership that has asked you to continue to run your own survey, and what is there sort of an addendum? Are there different components that we could fold in to make this less burdensome? Because we are trying to find that right balance. This being the first year, we may not get it perfectly right this year, but want to and are very committed to iterating this and evolving over time so that it's imposing the least burden, but yielding the highest value.
Thank you.
And I'm happy to, when we have some additional time to do our deeper dive CHIA briefing, happy to have folks from the team that are really close to this, that have been part of those extensive conversations around how do we figure out the right list of providers within each sector, make sure it is representative, because we didn't want just the big providers that are sort of always reflected in data, but how do we get from all corners of the state, large, medium, small, and so happy to sort of speak to some of those details when we need, and happy to provide this level of detail sort of to any of the council members, if that would be helpful.
Thank you.
I will say the team there's a lot of work that went into this, and refining the survey tool and the survey list.
Laura.
I totally agree with that assistance for the smaller, because, you know, often when we think of HR, it's the sister-in-law that manages the front desk or the office. I mean, it's just not HR in that sense, and they're really strapped. So and that's exactly the one we really want to hear from. Kat, I want to just commend you on an excellent presentation and the responses to the questions. Really well done. The only remaining question that I have is, I assume the answer to this is yes, but I just want to verify, when we're talking vacancy and turnover rates, we've given them a formula, standard calculation of that.
So actually, we're asking for the number of vacancies and the number of folks who have left, so that we can do a standard calculation of vacancy rates and turnover rates. And so we're sort of asking for numerators and denominators separately throughout the survey by occupation.
Yeah, that was kind of the bane of my existence when we were looking across, when I was a hospital administrator, we look across different sites of hospitals that we had, the standardizing just how we calculated turnover and vacancy rates. So thank you.
Absolutely.
Great. Yep, Sandra.
I'm not sure, I'm sure you've shared this before and I just can't recall, but listening to Meredith's comment, are we going to be able to drill down into this data by the organizational characteristic of private equity ownership? Is that one of the pieces of organizational data that was collected?
Kat, can you speak to there was some level of like independent versus system, but Kat, can you speak to some of the statistics?
Yeah, so on the survey itself, we do ask about certain organizational characteristics, like whether you're independently owned versus owned by a larger system, organization size, we are hoping to get at region, we're hoping to get at, and then some of the other stratification variables that folks might be interested in. We might be able to pull those from other sources and append those to these data so that we can then stratify it. So we don't ask specifically about private equity ownership, but if there are other, you know, publicly available or resources that data sources that CHIA has, we would likely be able to append that information to our data to facilitate that stratification.
Thanks, Kat. I think that would be really interesting.
Do you have a question?
Yeah, and sort of a comment first that I think goes along with a lot of what was being said about like non-response in terms of to Jean's point about smaller sort of providers, be harder for them to sort of respond to because of the lift and so forth. I think it would be good when analyzing to look for, even not just across the sector by each sector, as Niels was saying, but within the sector, to look at non-response to see if there are big differences. If all the big providers have responded, but the small providers haven't, then the data isn't going to be sort of accurate for that, or need to be sort of, as you were saying, sort of weighted across that. And it could be like, also like you were saying, region or various other sorts of things. So that, but it sounds like you're putting all that together. The other thing is just sort of, I think, I don't have any good solution to this, but you know, I think it's an annual snapshot, right? Just once a year, the plan is to do the survey, which is great to have that data once a year, but I think it makes it very difficult then that's a really long time to look at trends, you know, in terms of being able to understand, oh, are we coming towards a new sort of, like, is it getting better or worse? You know, it's going to take a long time to sort of build up those types of things. I mean, one way around is to try to have some time frame within the survey, break it down by month or something like that, so you could see, but again, that makes it more burdensome to collect and to provide. So
yeah, one of the things that we did build into our contract with our survey vendor is the potential to do what we've called pulse surveys. So where we wanted to do that, double click into a certain sector or issue that is cross-cutting. And so that is something that with that exact concern in mind, is how can we look at, for example, there's some industries experience seasonality trends and challenges, for example, in the summer months, and how can we, so I think the short answer is there we do have a mechanism if we wanted to do a deeper dive in shorter windows or increments to do that focus. We won't be able to do it across all 10 sectors, across all of the various metrics. But these are some of the very things that we'd love to get your feedback on where we should be doing that drill down in with our survey vendor.
Any other questions for clarification before we move into the more specific areas that the team wanted more insight in? Okay, oh, Laura.
Just a follow up to that question. Did I hear that right? That there may be an opportunity to do sort of a periodic, just on a particular topic, more frequent every 2 months or so on just a very narrow, so it's not a heavy lift, but it's really a prioritized area. Did I hear that correctly?
That's right, yes.
Thank you.
Okay, great. There were three sort of areas the team would love some input from the council on. I'm going to move it around a little bit, ask the thoughts about analytics in terms of core metrics, because this is a group that has specific questions as faith them and probably has some insight of what the right questions are. What should be reported? What are people interested in? What would be helpful?
So you're looking at vacancy and turnover, but anecdotally, one thing I've heard about is burnout manifesting in sort of more incremental ways, people scaling back their hours rather than exiting altogether. I've also anecdotally heard concerns about the tenure that a nurse has been in the field. If the workforce getting younger as older people leave, having potential quality implications. And so I'd be curious if there is a way, again, recognizing the burden issue and recognizing that these may be difficult to standardize across provider types, but those might also be interesting to look at. They might be nuances that you don't capture in simple turnover exit rates, but might be having.
Yes, yeah, I think that the tool, so taking it out of backwards, the tenure, I think those are data points and metrics that we're hoping to explore getting out of the supply side data. But to your point about, and I think it's a really good one, that pure vacancy rate does not tell the whole picture about why there's facilities are having a hard time filling their staff schedule. So Kat, can you speak to if there are components of the survey that look at changes in the general staffing patterns, like are more going to part-time or more going to 4 days a week? To what level of granularity does the survey get?
Sure. So the closest thing that we have in this current version of the survey is we ask about what the significant challenges organizations are having in terms of recruiting staff by select occupations, as well as significant challenges in retaining staff for select occupations. And I know within that section, we do ask if burnout is one of the reasons, is one of the things that is a significant challenge to retaining staff. And so one of the things that we could hope to do, or could propose to do in an analysis, is that if we know that burnout, for example, is one of the top challenges for this select occupation, how does that sort of look? What does that look like next to the vacancy rate? What does that look like next to the turnover rate for a select organization or sector? And so it's not quite what like the granularity that you're suggesting, but it's something that we're doing right now. And I think, yeah, certainly in later iterations of this survey, we could think about really refining that, those questions around recruitment and retention to better get at what are some of the challenges in the workforce.
You're also reminding us that this is the beginning. This is the first. It's going to change immensely over the next few years. So yeah, these can sometimes be ideas to put into the next time if you do. It doesn't have to all be perfect first. Laura.
And just thinking a little bit about how organizations might be coping with this. So they shut down a unit. It makes their vacancy rate look better, but they're not servicing the population in a way that they may have before. Are we anyway kind of getting at, did you close services to make your rate look better? Or not to make your rate look better, but because you couldn't staff it.
If
Sure. So we do have just a few questions on how has the workforce crisis impacted access at your organization? And one of the things is like, did you have to cut staff or did you have to close a unit? There are some options like that. And I think we also have sort of an other, please specify, and we're hoping to use what we get in that that other box to sort of inform some of the options that we might put into a later version of the survey. But yeah, exactly. Like to your point, it's important to the numbers themselves on vacancy and turnover are not going to tell the whole story. And so we're trying to capture a couple more pieces of information to build a fuller picture.
Thank you.
David.
I think some of the ideas that you've already put forward make a ton of sense to me in terms of some of the stratification on the analytics. I think, when I think about what is really novel about this data set is that it's standardized, it's objective, and it's cross-sector. And so when we think about kind of the association surveys, like they may give us a really good picture of what's going on with registered nurses in hospitals. But I want to know, like, how is that compared to registered nurses in nursing homes? How is that compared to registered nursing at community health centers? And so thinking of and being able to have that be standardized in a way that we can actually make meaningful comparisons and not just be smashing different association surveys next to each other and saying, oh, that's apples and oranges. There's no way that we can draw conclusions. So it's on your list of things to do. And I just wanted to emphasize like the cross-sector occupations for statewide analysis, I think is really interesting. The ideas of breaking it down by independent versus part of a system, for-profit, nonprofit, some of the occupation or the kind of organizational factors and variables I think is interesting too. And, again, it will kind of depend on what level of granularity you're going to be able to share this data and with whom. But, for example, there are other, if depending on how that looks, we could start connecting other data sources to those organizations as well. And Sandy, to your point, we're in the process of procuring a data set, proprietary data set that looks at all the private equity transactions in healthcare in Massachusetts over the last 10 years. And so we'll be able to know what those entities are, by name. Now, how we could think about linking that, we'd have to probably be a little bit careful about that in terms of getting to the names, but at least by sector, maybe even saying, okay, this is what's happening in the skilled nursing facility space that we can see PE versus non-PE, by sector, maybe not individual organization. So great work. Those are my thoughts. Not a question. Thanks, Kat.
One more, just a question about sort of the reporting, like how to do the reporting, what to include on the dashboard and so forth. The first question is, are you expecting to do sort of like a static dashboard sort of thing, or like an interactive type of thing where you can sort of slice and dice it yourself?
So sure. So we're proposing an interactive dashboard that would allow folks to maybe zoom in on a particular occupation, zoom in on a particular region, as well as a lot of the other stratification variables that folks have recommended as they're available. But it is open to discussion. I think we're really looking to the council's feedback on how we might present these data.
I think that's best. I think that sort of, it's hard to, I mean, there are a lot of really great ideas in terms of what people are interested in viewing by, but you can't imagine everybody's uses, right? And so the interactivity and being able to select the dimensions and doing all that sort of interactively, I think it gives the most flexibility next to having the whole data set, right? And so I think, and I'm sort of interested in what the sort of the level of is it possible to have the raw data available in some sort of form that there aren't privacy issues or that type of thing, or like what are we thinking there? Because then you could join it depending if it's not anonymized or whatever,
So that was a question either to Lauren or to Kat.
Yeah, I mean, I think that we'll need to take back the raw data piece. The wage piece is the only thing that comes that's jumping out as a political, where there might be potential legal issues with sharing like entity level wage data. The rest of the raw data, and again, would want to just think through this a little bit more about, are there any concerns with releasing that out? And maybe there's a way that we can sort of anonymize the entity name, but you can just look at it like nursing home 1, nursing home 2. This is what they're offering in wages. This is what their vacancy. So we're not sort of tying it to actual names. So let's take that question back as to what would be potentially available as in a raw data set. And
Or maybe to share with another sort of part of the state infrastructure, as long as they agree to the, to a set of, not sharing further or something, so that they could join to another data set or something.
Yeah. Question to the council. Do most of you agree with interactive? Nodding.
Yeah.
Thank you. Laura. You're muted.
I don't know if it's possible to, in addition to that interaction, have an interaction somewhere on the site where we can ask a question of, did you want to see something that you couldn't see this way? Or was there something else that the way of displaying the data? Sometimes we can get great ideas by incorporating a little button like that, did you find what you were looking for, or were you able to get at what you were looking for? Not always, but might be helpful.
yeah, that's a great idea, especially as we're heading into the planning phase for 2.0.
Other thoughts before we end this discussion and move on to some others? I don't want to cut it off. We do the time. You got what you needed, Kat.
That's great. Yeah. So we did have a few more questions, I think, maybe on future survey planning. I know that folks have provided some suggestions that have been great. I just wanted to give time if there's any other things that CHIA might consider as we move into planning for 2024.
I'm wondering if it's a little bit related to the 10-year comment at Adriana, because we measure tenure actively. There's actually a very steady decline. So losing a new worker is very different from losing a long-time worker. That's real erosion of workforce quality. So I'm wondering if there's a way for us to think about not just the turnover and the vacancy, but also overall workforce quality. So for example, is there changes in their education levels, computer literacy, language proficiency, training levels, et cetera, et cetera. Again, in some of the sectors, you see a real change. May not be the case across the board. Just as we think about workforce changes, just the quality index, if you will, as an opportunity.
Yeah, those are some great suggestions for as we think about the supply side, which we are hoping to integrate into the staff board in the interim, and not necessarily waiting for the next 2.0 survey, but this is something that we're hoping to from other data sources pull, and I think those are some good dimensions that we should be looking at for the supply side. I don't know, Kat, if you have specific thoughts, or if you feel like those are data points that are attainable, or that we could get from current licensure data.
Yeah, I think I agree with you, Lauren, that this might be information that would be better retrieved from the supply side data. I think we could get averages at an organization, maybe what's the average education level or things like that. And I'm not sure if that's granular enough to answer the question, but it's definitely something that we can look into and look to other state surveys and other association surveys to see how they get at some of this tenure information for sure.
Great discussion. Thank you. We are going to turn to some of the other priority areas. And again, I think we'll have a probably shorter, good discussion. I guess I would ask an incredibly naive, stupid question before we move on up, which is, so 20% of the people are sending in information. Are they going to get all the information though? And then they can sit there happy and say, wow, I pay X, they pay Y. I mean, to be honest, if I was answering that, would be perfect. Did anybody understand that question? Let me try it again. I would hate as a provider or anybody, and certainly whatever, to give you any information about wages, for example, or turnover or anything else. So it would have to be very confidential. But I would love to know how everybody else is doing. And this is going to be public. So why would I participate? That's, I know, crazy, but
So I will. I think it's a fair question. I think that they will not be able to see like, okay, I want to look at the hospital or nursing facility down the street from me. They won't be able to look at that granular level. They'll be able to see as the averages, right? But I think your point still stands. And I will just maybe plug in the fact that I know EHS, the administration, the legislature have all sort of offered their continued support and have asked, like, let us know how we can be helpful if you aren't getting responses.
Yeah.
You know, at this point, this survey is voluntary, and I think that it's been great to have the voluntary buy-in and
Huge.
partnership.
Great.
But I think that you know, I hope that we don't have to go down, you know, to at a later point in time in order to increase participation, some like a heavier mandate or requirement. I think we are certainly not there yet, but I know that the legislature has been happy to put that on the table if needed. And I think that really more speaks to the importance of this data and information.
and I want to say hugely important. Everybody I talk to is talking about this issue. All my family is in healthcare in some way, shape, or form, and they talk about it all the time too. So there's a huge amount of energy in getting this data and having a good conversation about it. I worry that, 20%, I guess, seems to me kind of low as a goal. And we're trying to figure out how to make it really a positive, because they should participate.
But that was part of the points about sort of looking at the organizations that aren't responding and seeing are they substantially different from the ones that are responding, right? And if they are, then that's a big problem, and you have to sort of, you could look at it statistically, and then sort of try to see how they're different from the population that is responding and try to adjust it for that. But you kind of need a representative sample, right, in order to get all of the information.
So this is a plea for enthusiasm, for getting participation, and using lots of carrots, because this is data that you want. It's really important. If you don't participate, it will not be meaningful.
And I would just say that I think that is exactly kind of the point I first was making about the bigger systems.
Yeah.
I think the smaller systems have different barriers, bandwidth, time, the system's capability. The bigger systems have all those resources, but they also have an interest in not sharing some of that information.
Right.
And so,
I don't blame them.
But
Especially
we are, as a Commonwealth, paying a lot of money to give to these organizations to help them with their workforce challenges.
Absolutely.
So I think it is very reasonable for state government to say, we expect you to fill out the survey while we're putting millions, hundreds of millions of dollars
I agree.
into workforce
I am not
initiatives.
disagreeing, but when I heard that we were being able to compare to, the hospital down the street, et cetera, then I misunderstood that, because I think that is scary. So being crystal clear on how it's shared, what are the privacy, and that this means you will do a better job as a system, you will have the data you need, you can improve. Exactly. We're in violent agreement. And it may be me just thinking 20%, since it is so important, and people really should say, wow, this would be great for me. I don't understand that would be 20% as a goal. That's my only question at the end, because it's really important and it's really great. And I hope it is a way to use policymakers to say, okay, now what do we need to do? Whether it's education, regulation, et cetera.
I don't want to belabor this point, but I would just say that the 20% is not, we're not just using sort of like a hard and fast quantitative threshold. I think the qualitative piece about, is this representative, is just as important to our sort of analysis of, do we have sufficient response rate to sort of like appropriately put this up on the dashboard to say this is this industry average. For example, for EMS providers, if we only had municipally owned and operated EMS providers responding, that might look like a high percentage response rate for the EMS industry. But if we don't have the Cataldos and the other privately run companies responding at all, that's certainly not representative. And so I think we would have to either heavily caveat or think about holding on reporting. So that is something that we certainly don't want to do. But I don't want us to get too fixated on the 20% threshold, because I think it is just one factor in our assessment of what is a sufficient response rate, or what is success look like for response
And I
rate.
want to readily admit, I have no idea. That might be an awesome amount in this kind of survey. I don't know. It just, as a person who doesn't do this, it seems low. So, anyway, good to have you interested. Yeah. Next topic.
Thank you, Kat.
Great job, Kat. Oh, don't just spin that fast. We wanted to thank you, Kat. It was a good job. And we've got Erin. We're going to talk about the primary care dashboard.
Yes. Yeah, awesome, great. So here to provide a quick update on the primary care dashboard as a little bit of a refresh and background. So in January of this calendar year, CHIA published our first ever dashboard on primary care to look holistically at the primary care system in Massachusetts. So the dashboard focuses on 4 domains, which are displayed here. So finance, so how much are we as a state spending on primary care? Capacity looks at workforce, so primary care physicians, nurse practitioners per 100,000, things like that. Performance domain looks at both access to care as well as access and quality of care. So how are quality measures doing? Do Massachusetts residents say that they are able to access care, screening rates, things like that. And then the 4th domain is equity. So looking at measures along all these domains broken out by race and ethnicity. And so at the last meeting, we did a little bit of a deeper dive on the dashboard and asked for feedback from you all on measures for future iterations, as we are currently working on the 2nd release of this dashboard. So on the next slide, so many thanks to this council for your robust feedback on the content of the dashboard. So based on all of your feedback, we have a list here of things that we are working to include in the next iteration of the dashboard. This is not reflective of all of the great feedback we received, but in terms of what is feasible for this next iteration, this is what we are working to include. So new measures include primary care physicians that are accepting new patients, the percentage of Massachusetts residents with a primary care provider. Previously, we were able to capture the percentage of residents with the usual source of care, which is a little bit broader. So many thanks to the strategy and research team who has included that in the health insurance survey. We also are looking at the percentage of visits that are delivered via telehealth versus in person. And then adding in additional stratifications to measures where we can or where data is available, and really focusing those stratifications on geography, race and ethnicity, and then payer and provider specific data to the extent that we have it. An additional new product coming up is, in addition to the static dashboard that we published for round 1, that we will update for round 2, we are working to create an interactive dashboard that will enable users to explore aspects of the data a lot more easily. So we're really focusing on the finance domain and on the equity domain, as those have more robust cuts available that would lend themselves to that interactivity to really allow a user to explore the various measures. In terms of time frame, we are working for this to be published in Q1 of 2024. So rapidly approaching. And I think I will pause here for any questions with anything I have just very quickly ran through, as well as to solicit any additional feedback that we should be considering either for this round in the next coming months or for future iterations, as we are kind of always keeping an eye of what is next and then what is beyond that.
Good summary.
Thank you.
Can you flip up? Thank you. Questions?
It's great that you took all of the feedback from the council. Do you have ways of collecting feedback from other users of the dashboard, like that are like feedback from just sort of general users or from other organizations that sort of use the dashboard?
Yeah, so to the extent that we hear back from organizations that use this, we're always very receptive to feedback. As part of this broader project, we also have contracted with MHQP as a collaborator in this project, and they also have really great connections and networks to users of this data and of this dashboard.
Yeah.
I have a comment. Really excited to see the next version of this. I had, I guess, two comments. One, I think the question of like, who is the audience for this is still one that I'd like to think about. Is this like researchers? Is this policymakers? I'm looking at the previous dashboard right now. I'm like, it's not really like for like members of the public to like go in and see what's going on with primary care, but I think it actually does contribute to something the public really does care about, which is what is the health of our primary care system. And anecdotally, people feeling like the wait times are getting longer, access is getting harder. So I think from a policy and research standpoint, it's excellent. I just continue to want to think about what the audience is here. And then I will put in a plug for maybe future versions of the primary care dashboard. We have done a lot of work around the provision of what we call low value care, which is tests and procedures and other types of healthcare services that the clinical community has decided does not provide any clinical value from choosing wisely. In other words, we have been able to use the APC to calculate how often patients are receiving these types of tests and procedures and labs, how frequently, and attributed to their primary care. A lot of those measures are primary care relevant. So I know that's maybe a measure of inefficient primary care use and spending, but if we're thinking about quality metrics, it's another way of thinking about kind of performance. So I'll put in a plug for that. Maybe not for January, but maybe for 2025.
We would love to add that to the list, and we'll definitely be in touch with your team on that. Thank you.
Anybody else? Thank you, Erin. That was great.
Thank you.
Thank you, very efficient. And we are going to move to Haley. Thank you. And Farber. And by the way, I'd like to thank you for having your staff present and converse with us. I don't know about other council members, but I think it's terrific to get to meet you and to, hear your work.
Great. Awesome.
And you are close to it. And I think that, all of you, by the way, not just you.
Yeah, for sure. Thank you. Good afternoon. I'm a senior manager on the strategy and research team here to just give a quick update about CHIA's health equity related data and analysis efforts. CHIA continues to support efforts to address healthcare disparities and advance health equity on several fronts, namely our health equity reporting series, which has brought to light some system level disparities across key domains like utilization, coverage, and access. Most recently, as part of that series, CHIA released a report on hospital utilization in Massachusetts, which we heard a little bit about at the top, that provides a comprehensive look at differences in acute care utilization by race and ethnicity. And we do have a number of planned future analyses that will focus on different aspects of health equity, namely total medical expenditure trends by resident zip code and residents' experiences of unmet health-related social needs. And these analyses, I think, will provide really important insights on sort of how social determinants of health impact the residents of the Commonwealth. We'll also plan to report on coverage, use, access, and affordability issues using newly available data from the 2023 Massachusetts Health Insurance Survey next year by race, ethnicity, and by family income. Other ways that we are sort of supporting equity efforts include CHIA's work with Mass Health to support the implementation of their health equity incentive program, as earlier mentioned, the 1115 waiver, and we're also supporting EHS's broader health equity work through the provision of data and analytics.
So to move on to the next bullet point here, in order to enhance and optimize our data and analytic resources, CHIA is developing a more comprehensive health equity strategy. And that strategy will really aim to integrate and coordinate CHIA's efforts with other related initiatives in the broader healthcare ecosystem, like the Health Equity Compact and other public and private efforts. Specifically, through this strategy, we aim to sort of standardize our approach to reporting across the agency, layering in an equity lens into all of our work when we can. We're also going to aim to create a health equity data roadmap to inform the agency's data collection, analytics, and reporting agenda in this space. And we're also this is going to give us the opportunity essentially to identify where enhancements can be made to our existing data sets versus, maybe exploring areas where new data collection or reporting might be necessary. And then finally, the strategy is also going to aim to enhance our health equity reporting products and the publications based on feedback and input that we get from some of our external partners that include obviously the council, industry leaders, sister agencies, and policymakers. So CHIA is really in the early stages of developing this broader strategy, and we plan to bring a lot more details to the next council meeting to solicit your feedback on the form and the substance of this equity planning work.
Thoughts, questions? Thank you for putting back the.
Just to tie a earlier discussion point back, what part of the goal of this broader strategy work is to lay that blueprint or roadmap, whatever overly used term we want to use. The goal would be to say what data reporting streams what gaps do we need to fill? I think one of the gaps that we mentioned earlier was payers socio data. Those are things that we're working to identify so that we can come up with this short, medium, long-term strategy of what equity data do we have right now? What do we want to work towards in the next year or two? What's probably a longer term arc, but data that we know is critical to these efforts. I just wanted to connect those dots and spell out what we mean when we talk about a data roadmap.
This might be a little bit peripheral, but have there been any changes or are there any changes to the health insurance survey anticipated in response to unwinding, Medicaid unwinding?
So I might defer to our MHIS survey experts in the room who have worked really closely on developing any new questions that have gone on to the MHIS.
I can start. Of course, it's getting more and more challenging, getting survey response, whether from residents or from organizations. That's one of the biggest challenges. We're facing most of the cost is really skyrocketing.
Yes, I'm with the team that has a survey in field right now. It's not cheap.
The good news is that we develop the strategies to offset some of the cost concerns and still being able to do more. For example, we did an expert design, where that almost we had the two substantial adding up, and that is one of the ways for us to add more survey questions without incur costs. And another thing actually related to equity is we're aligning our data collection, Oversight, question, with CHIA and other, standards that we have an organization around that. And another big part of it is we gradually added different subdomains of social determinants of health, which, enable us to really look at all the access, coverage access, utilization for the portability measures from the sort of, SBOH perspective. There's some good things happening.
So if I understand, you're going to come back at our next meeting and, because it sounds like there are a number of different things in the health equity space you're talking about, the one we just talked about with the HR, the survey we're talking about, and give us a full picture as part of the overall strategic plan, because it's such an important component. That would be great.
I think that's right. I think our goal is to sort of create this strategy to encompass all of the work that we do at CHIA to make sure that we are sort of reporting on these really important health equity items in a really comprehensive way. And I think that the EHR project absolutely fits into that work. And we will be back to share more details when we have them.
Great. We see the whole element.
Yeah.
I just have a very quick question. The unmet health related social needs, what's the source for that data? Is that the MS or?
Yeah, so we
Okay.
use the MHIS survey specifically to sort of source that information. We ask a number of questions just sort of about residents' unmet needs as they relate to healthcare, and we use that as our data source to analyze that.
You don't call it MS, you call it MHIS?
The Massachusetts Health Insurance Survey, yes, I do anyway.
More acronyms, why not?
Yeah.
Sounds perfect. Terrific. Thank you, Ellie. Great. And now it's time for the interview. And who are you asking to do this? Jamie. Hey, Jamie. Hello.
Just going to do a quick overview of the APCD for new members and for anyone that needs a refresher. The APCD is CHIA's largest asset by an order of magnitude, containing more than 5 years of highly granular claims data for more than 80 payers plus Medicaid. It includes a variety of data, medical, pharmacy, dental, enrollment files. We have a little bit less data now since the 2016 Supreme Court ruling, removing self-insured accounts. The data gets submitted to us in a pseudo-identified way, so it allows us to look at the data without having PHI in our system. And we do extensive work to de-identify it, normalize it across submitters, version it, and track people over time across time and plans, and add analytic enhancements to the claims data. We launched a project to enhance the APCD, and we call it the EAPCD. The goals of this project was to standardize and enhance the analytic functionality, to create new flexible analytics to enable critical industry recognized groupers, hierarchies, methodologies, etc. We basically are trying to remove some of the need for our partners and users to engage consultants to work with the APCD. We want to improve result consistency between users and reduce time to answer by removing significant user data preparation steps. This system will create a more user-friendly interface. It'll remove burden from sister agencies to transfer and load and store all this data, because as stated earlier, it is a very large data set. And it will enable a wide range of users to easily and efficiently produce reports, queries, and data visualizations. Provide ready access to data model documentation, as well as thorough training on data model and reporting solutions. And I know for the newer users, you don't have a lot of the background on this. If you ever want more information, we're happy to provide it. So I'm here just to provide a quick status update. Somewhere next slide. So we had previously created a kind of final deliverable list to close out the development portion of this project. We're kind of at the tail end of implementing the last development items, which we're hoping to implement later this month, and be able to see what those look like. The biggest undertaking right now is the documentation portion. So we are covering the system documentation as well as end user documentation, things like data dictionaries and useful documents for the people using the data. This is a very valuable and critical piece of the solution. So we're really trying to make sure it's very comprehensive and detailed, because this is the part for we're handing it over to you to use. You need to understand what it does, what's in there, and how to access what you want to access. We're currently working on our contract renewal. The current contract expires at the end of March. So we're trying to construct a layout and the terms for our new agreement. Our next steps at this point is we're revalidating our original use cases for the solution, and we've broken them out into 4 categories, and that's how we're sort of looking at the renewal. So the host site, the data model, the flexible analytics, which is the tool that enhances the data, and the BI tool, which is the end user. And as part of this process, we wanted to create an informal advisory board that includes internal and external members to help inform future decisions and planning. So if anybody is interested, please let us know. But we want to kind of create this board once we've become operational to decide what happens next, make group decisions on how we should change the system, update the system, things like that. Any questions?
Questions? It is great to see that we are coming to the end of this phase. There's never an end, really. We know that of the project, which would be absolutely wonderful. I don't know about anybody else, but I'm delighted to see a focus on documentation. It really matters, and it doesn't excite people a whole lot. It's really great. And I urge anybody that has an interest in the advisory board to reach out to you. Yes, you got a volunteer?
I'm sure we're already penciled into that advisory board. I just a comment for the group and for some of the newer members who have not been a part of this multi-year journey with the EAPCD. I think we at the Health Policy Commission, I think we are referred to as a power user of the APCD. It is core to so much of our ability to understand performance at a very granular level. We just released our annual cost trends report, and I would probably venture to guess that 70% of the data analysis included in there was sourced from the APCD, and the other 30% being the case mix data that CHIA also collects. So just an incredibly important project. I think it has taken some time, and I just want to voice my appreciation for the CHIA staff who've been at this for many years, for continuing on this sometimes difficult journey. I think Director Peters, for you coming in new to the organization at the beginning of this year and making this a priority is certainly been something that I have noticed and appreciated to continue to make sure that this project stays on track. I think from HPC's perspective, I think we probably are still going to be in a position where we're going to be wanting the full APCD data set transferred and housed on site. But we nonetheless do think that the EAPCD is going to help us a lot complement that work. And I'll just mention a few things in particular that I think are real benefits. One is just the recency that the EAPCD provides. So my sense, and maybe someone here can correct me, but we're collecting that data on a monthly basis, quarterly basis. So we're going to have access when we can look at that data to actually be able to analyze data from this calendar year, within the last 12 months. The report that we just did, all of the APCD analysis we did was on 2021 data. That's a report that we released at the end of 2023. Anything we can do to get more recent information and to be more on top of this is going to be just so spectacular. And you talk about use cases. When we have penciled in already our first use case when we can really get into the EAPCD, which is going to be looking at the utilization of some of the new weight loss drugs in the commercial market. That's something that when we look at 2021, it's not there at all. And I suspect when we look in 2023, we might find some interesting things. So the recency of the data and being able to react to kind of real-time changes in healthcare utilization and services, I think is really important. The second is just the number of health plans that are included in the EAPCD. When we do our analysis off of the main file, we really just kind of have to focus on the biggest health plans. So we typically do Harvard Pilgrim, Tufts, Blue Cross Blue Shield, and like 2 other health plans. There's a lot of health plans in Massachusetts. Some of them are smaller, but it will help us be able to do things like look at United and Aetna and Cigna, maybe not just the local nonprofit plans that we've focused on in the past. And then there's built-in functionality that is going to be part of the EPCD, having bundles and groupers and things that are just kind of locked and loaded in there. That will save us a ton of time and not having to contract that out or to pay other proprietary vendors to do that. So that was my continued to be a cheerleader for this project, understanding it is still a big boulder that we're all kind of rolling uphill.
Perfect, Dan, thank you, because it has been a tremendous amount of work. It is still going to be a tremendous amount of work, and it really does matter. It's incredibly important. And, you know, we really are a leader in the state, which is pretty exciting as well. We are ending on time, which is always our goal. Thank everybody. It was a terrific conversation. People really participated, which is much appreciated. I think there's a lot to take back and mull over, whether it be the work on temporary workforce that we talked about, the discussion around primary care and adding choosing wisely, health equity and putting it together. Look forward to having that as part of the plan at our next meeting, and ending with fingers crossed for the APCD and they get it all documented. And if we have a good report again at our next meeting. And if anybody has any other agenda items, please let Director Peters know, and she will be happy, I'm sure, to add it on. And it is great to have you, and it's great to have the team. And we thank you all. We know this is a lot of heavy lifting. Thank you. And welcome and goodbye, Meredith. We'll miss you.
Hi, I'm leaving you in good hands with Adriana.
Actually, I think the lecture in the next Tuesday.
Okay.
Bye all.
Bye.
Bye.